This week's topic, I think I said 2 weeks ago we were going to start last week, but moving on into the therapeutic interventions. And so for the first topic or the subtopic is modalities. And so there's a lot of overlap with the topics that I want to cover. So things like thermotherapy, cryotherapy, those will have a separate topic because I think they're pretty broad and they have a lot of different specific applications. So I wanted to create a separate week for those. Things like manual therapy, which is going to include things like instrument assisted soft tissue mobilization, things like cupping therapy, massage, that's going to have a separate week as well. So there's going to be some overlap, but I'm going to try my best to exclude those things for tonight's topic and talk more about the standard modalities, the electrical things that need to be plugged in. So for the overview of this topic, this is kind of the way that my brain thinks about modalities, how I'm applying them in a clinical setting. The options available, what modalities do I have? And so you have 1.5 million modalities out there, and not every athletic training room is going to have every single modality. And even if you do, then you need to know which ones you have available, which machine, which brand sometimes, and then that will kind of influence what your best practices are. Because if you are indicated to use something like ultrasound, but you don't have an ultrasound unit, okay, well, how are you going to do ultrasound if you don't have it? So you need to know what you have available. From there, you need to know what is your intended outcome. What is it that you're trying to achieve by doing a modality? Doesn't matter what the modality is. What are we trying to achieve with this individual athlete? So whether that's reducing pain or whether that's promote healing, or if that is to create some kind of placebo effect and create some motivation, whatever it might be, you need to have an intended outcome in mind. That's going to guide your decision for which modality is most indicated. And then lastly, I think about timelines. So for one, you're looking at like pre-training, post-training, how long is this treatment going to take? But then also you're looking at the different stages of healing. So options available. As I said, there are 1.5 million, and this is definitely not an exhaustive list. These are things that I see pretty commonly in athletic training rooms at any level. So there's a lot of, even high school, college, professional, there's going to be some of these things where it's like, oh yeah, you're only seeing this in like elite clinics or some of the wealthiest, like big football programs in like Texas, for example. They're going to have some massive high school football programs that are going to have more than college settings, but you're also going to have some pros that don't have all of these things. So there's give and take, but a general feel of options available. So Hivamat is a kind of a manual therapy-esque treatment. It uses electrical frequency to then create a vibration, kind of sound waves that are being transmitted through touch. And so you've got the clinician who's providing some kind of a massage. Typically, I've seen it used for edema reduction, swelling, but it can also be used just for pain. That extra little bit of vibration therapy does reduce pain and soreness. So you could use it for either of those. Phototherapy. So this is things that include light. So red light therapy is definitely trending. If you go on any kind of social media right now, everybody's selling it. I have yet to see much clinical evidence that there's a broad, what would you call it, system or individual level effect of red light therapy. Same with low-level laser therapy. The interventions, they occur at a cellular level, and these are such a small kind of spectrum of application. Like red light, you get a little bit more broad, so you can kind of treat it more like sun, where it's affecting tissue at the hands and the feet, for example. But low-level laser, you're putting that tiny little dot on one little body part, and you're holding it there for 5 minutes, and you're telling me that's a strong enough signal to transmit some kind of tissue healing at the systemic level or at the individual level? No, thank you. Electrical stimulation. This is e-stim or stim. Pretty much everybody has it. There's a bunch of different variations of it, whether that's a stim unit, combo unit, a TENS unit, Compex, NMES. There's a bunch of different applications of electrical stimulation. Electromagnetic therapy. I made up a word there. Electromagnetic therapy also has some slight modifications, but it's still an electrical signal that's occurring. And so these things are driving different magnetic frequencies into the body or around the body. The goal is to basically modify the body's healing process. Whether or not it actually does, TBD. But there's some interesting I forget the name of the actual like methodology, but the unit is called Winback, and they've got one. It starts with a T. I forget the acronym for it, but it's supposed to kind of drive these electromagnetic fields through the body to promote healing. Iontophoresis, phonophoresis, these are both different methodologies. So the phonophoresis uses ultrasound, iontophoresis uses ions, and you're using basically magnetic poles to drive medication through the skin. And so the concept here is that you're taking some kind of a topical medication and you're driving it through at a faster rate than you would if you just put it on the skin. I'm a bit of a skeptic when it comes to these things because the body is going to decide how much of these things are getting through the skin based on the semi-permeable membrane. You're not going to change what the body wants in it by putting a little magnet on the side of it. You just don't open channels that way. That's not how it works. So I'm a bit skeptical when it comes to both ionto and phonophoresis. I would have to look at the literature to see if it actually achieves what it says it does. But I think that a lot of the improvement would come from sham or placebo mechanism. I would think that there's probably some medical benefit, but there's probably not as much as what people are going to attribute to it. Shockwave therapy. This is a pretty expensive treatment. I don't think many high schools are going to have this. The first unit that I ever saw was when I was in undergrad at the University of Iowa. I forget the name of it. STARS, I think. STARS Medical. Basically, you're taking what would you call it? A mechanical head. And so we used to call it the jackhammer. And so basically it's driving this mechanical head through a really compressed chamber. And so you're sending these mechanical waves through the transducer to then kind of transmit into the body. And so it basically feels like you're getting electrical signal. It feels kind of like you're getting shocked. But in reality, there's nothing electrical going on here. You're actually using mechanical signal to then stimulate these different tissues. Ultrasound, similar, I suppose, in application. The transducer is applying a sound wave that is, again, creating kind of micro vibrations that are going to stimulate different things based on where you're applying it. This tissue or this sound wave is going to be absorbed differently by different tissues. Typically, it's absorbed by more dense tissues, and then it's going to typically it bounces off of bone, but you also have some bony absorption, and so you have to be careful with periosteal burns if you're sending this kind of like deep heating is what we call it. If you're sending a lot of fast vibrations through a tissue and then it's vibrating at a really high speed, you create friction creates heat, and then you're creating these burns. So you get this kind of, we used to do it as part of our like lab when we were learning to use ultrasound, is you leave it on a superficial bone. So like something like your hand, for example, where you don't have a lot of tissue surrounding it or blocking the bone. You put the transducer right on their head or on their hand, and then you are basically letting it sit still until you turn the dosage way up high so that it's submitting this really high frequency. But then you just basically, it kind of feels like a toothache where it's kind of this burning, aching sensation. And you're actually causing a little bit of bone damage. Not enough to really be concerned with it, but if you left it long enough, you could. Most of the time, as soon as they feel that, they're like, ow, my hand hurts. I don't want to do this anymore. So you're not going to cause tissue damage or bone damage, but something to be aware of as you're applying it. Intermittent compression, these have a pretty wide range as well. Pneumatic compression, the most famous of which is Normatec, but there are also, what's the other one? Recovery boots. And now that everybody and their mom makes one. So there's, if you go on like Google or Amazon and you look for these, like there's recovery boots that are, I don't know, probably $20 by now. So there's a lot of different brands that are making these now, but effectively what you're trying to do is create this kind of chambered compression. Actually, I think Normatec patented the chambers. So I think most of the other ones are just doing squeeze and release kind of a compression technique, whereas the Normatec starts at your feet and it's actually pumping it up the legs. And so that, at least in theory, I'd have to see the literature if it's actually more effective by following the body's natural rhythm. But the Normatec idea is that your body drains any kind of lymphedema through the lymphatic system, which has all of these one-way pumps. And so if it has a valve that's blocking backflow, you want to push it through the valve, and then the body won't let it come back down. So you're squeezing it out of the feet up into the calf, from the calf up the thigh, and then it's draining ultimately in the stomach. But you're trying to follow the body's natural return system. Again, I don't know if that actually has been shown to be effective or more effective than just squeezing tight, or even in comparison to something that's really low level intensity, like walking. You definitely create that bodily pump by creating some circulation and the muscle squeezing. So I'd be curious to see what the literature is on that, but I haven't seen it. I haven't really looked for it. And then another one that's growing in popularity is blood flow restriction. I think this one gets misapplied a lot. I think people talk about, and they're marketing it now as, if you want to take your training to the next level, do BFR. Put these things on your arms while you do bench press. It's like, okay, let's stop for a second. Let's think about what BFR actually does. BFR cuts off circulation. It drives this, one, chemical signal, and two, pain signal. And your body is responding to those two things. The pain signal and the chemical signal happen so much stronger when you're lifting actual weights than if you put BFR on. BFR, I love post-op and I love for pain modulation, but I hate it for the purposes of like getting stronger. Just because it feels like you're doing more work doesn't mean you're actually sending signal to get stronger. The mTOR pathway is signaled much stronger by doing actual rehab and doing actual strength and conditioning work. So the advantage for me is when you are not cleared to be doing these things. For example, let's say you just had foot surgery and you can't squat. You can't do lunges. You can't do anything with your legs yet. The only thing you can do is like a quad set or a straight leg raise or whatever it might be. And you can stimulate better return for those low intensity exercise by doing BFR attached with it. But if you get to the point where you are cleared medically to do any kind of lunge, squat, hinge pattern, those things are going to facilitate so much better the strength gain than BFR will. And then, like I said earlier, I have separate topics for things like thermotherapy, cryotherapy, manual therapy, and instrument-assisted soft tissue mobilization. So we won't get into those things, but those are coming in the next couple of weeks. Any comments, questions so far? Obviously, just listing out the different options and what they do.
Yeah, I remember the first time I was ever exposed to the HIVAMAT and shockwave therapy was down in Houston. So that was pretty cool to get some exposure working down there with you guys. The HIVAMAT was always interesting to me because you always had to glove up, but then use like the powder as what's the term? Like you use the ultrasound gel with you know what I mean?
Transduction.
As a transducer. So yeah, that was really cool. But like you said, a lot of different options. So when it comes to modalities and physical therapy, usually in my clinic, we're pretty limited to like the basics, e-stim, ice, heat. And most of the time, I always preface that by telling people like, this kind of stuff is a Band-Aid. It's never going to like make you stronger. It's never going to heal tissue quicker. but if it creates a window of opportunity to where we can have a better session and get you to move with better quality, then in my eyes, it's worth
God, you're such a physical therapist. You would say that.
it.
What would an osteopath say? No, I'm kidding. I agree 100%. And I think the evidence is pretty clear that the actual therapeutic exercise has the largest effect on pretty much any pathology. If you're doing the exercise and doing the rehab with high quality, that is what's making you better, not necessarily these modalities. These modalities have these different intentions of whether it's healing, and we'll get into this on the next slide, healing, or if it's to reduce pain. And if I can reduce your pain to the point where I can increase your exercise, now we're going to make progress because the exercise is driving that recovery process. If you come in with so much pain and you're like, all I can do is sit on a table, okay, we're not going to get too far with that with your rehab. We're going to do some mobility work, and that's about it. But if I can apply one or two of these modalities, get you feeling a lot better, trick your brain into perceiving that you're much more competent and able to move, now we go through your exercises, and that's what drives that rehabilitative process.
I think that's spot on. And I have that conversation with a lot of different people. And I think historically, um, there was a lot of emphasis on modalities. And I think way too much. Like if you're spending 20 minutes ultrasounding somebody, I think you're missing out on a lot. And I agree. The therapeutic exercise and the therapeutic activities should always be the real meat of potatoes of what you're doing in PT.
Yep. Yep. I agree. Remind me when we get to the literature, or I forget what I even call it. Hang on, let me skip ahead. Yeah, the literature review. So the St. Louis University, the approach to care for therapeutic modalities, that video is kind of comical because they explain what you just said, and it's definitely outdated, and it's a bit like redundant. Nobody does this in the real world, but they talk about things like preparing your patient for the modality application. And I think that there's actually value to that. It's something that we miss a lot of times, where we explain what the modality is, what it does, how it's going to help them, and then you start to get the psychological buy-in. And this was also resonated in a different paper. I didn't choose for the publication review this week, but there was a paper while I was looking through these that I was reading that was showing, and I'll send it to you if you want it. It was showing the timeline of, I think it was the 1970s, the 1980s. What was the other one? It was like 1985, 2005, and like present. And it was showing all these different applications of what was considered important in athletic training curriculum. And interestingly, they went through, like, modalities was super heavy in like the 80s, 90s. It's kind of backed off a little bit since then. But one of the things that I saw that was interesting was the psychological component was emphasized in the 70s, and it dropped off. It's since been released in terms of importance in the athletic training curriculum. So that's something that I think is kind of interesting. But like I said, I can send you that paper if you want it.
Yeah, I think that'd be really cool to have.
So you can see a historical perspective in terms of what people think about different modalities, but also like the broader like exercise was like always perceived as the most important. But you can see the different components in that curriculum.
Yeah, it's
So
very
for the intended outcomes, again, there's a bunch of different outcomes that we can target, and I think that this is where it's important to drive your decisions. What is it that you're trying to achieve via these modalities? So is it pain modulation? That to me is the biggest one that we see all the time. Athletes come in pain. This hurts. I don't know if I can train today. Okay, we apply this modality. We make your pain come down, and now you're much more able to get into some movement, and then that prepares you for whatever the practice is. So pain modulation is definitely a big one, both in terms of the time lost and the non-time lost population. So the ones that are still trying to stay active in practice, but also the ones that are in the rehab, like we just discussed. If I can bring your pain down, now your rehab is going to go a little bit further than what it would have. And now we're making progress because of your rehab. There are neural outcomes that you can achieve or try to achieve. And the way that I think about it is sympathetic versus parasympathetic. You can for sure get into the weeds with all the different like local nerves that you're trying to stimulate or facilitate, all the different nerve types, whether it's what is it, alpha, delta, like all these different like nerve specifics, and like gate control operates based on that. Afferent, efferent, like you can get into the weeds pretty thick here. So when I think about neural, I think more like global neural. What is the body's response to this modality? Is it going to be more sympathetic, more fight or flight and kind of activation? Or is it going to be more parasympathetic, kind of rest and digest? Is it going to prepare them to relax? So if I'm pre-training or pre-practice or pre-game even, I typically want them to be in a more sympathetic state. So when I'm going through some of these treatments, I want this thing to wake them up. I want this thing to really stimulate them to then get them going. I don't want to put somebody to sleep, which I think massage does a lot of time, is depending on how you're applying it. If you go through a really slow massage, or even the sedative effect of, like you were saying, with hot pack, you have to be aware. Yes, we think it warms up the tissue and it makes them more pliable, but it also has a sedative effect. So if the sedative effect of the hot pack puts them to sleep, now it doesn't matter how well they're moving or how well they're stretching, because they're asleep on the table. So you kind of have to be aware of all of the aspects of your treatment. But like I said, so when I think about the neural implications, is it going to be something that's more sympathetic or more parasympathetic influence? Tissue quality. I don't remember where I was going to go with my thought on this, but I think it was something along the lines of restoring normal tissue. So if you have some kind of soft tissue pathology, I absolutely, with a passion, I hate the word adhesion. I think it is overused, overstated. I don't think you can feel any kind of true adhesion that you supposedly have. I talk about this with my students all the time. Anytime I'm a preceptor and they say, oh, we have to break up the adhesions. Okay, you realize that a muscle fiber is the thickness of a human hair, right? You're telling me that you can, through the skin, through the subcutaneous fat, you can feel the difference between a straight hair and a curly hair? No chance. Maybe if you have like a large enough effect size where it's not at the cellular level, but you're actually having the muscle tissue, maybe you can feel some increased muscle tone, is the way that I typically encourage my students to speak about it. If you have some kind of tight, quote unquote, tight tissue, we're not obviously testing for tension, but if you have an increased muscle tone, if I want to restore that, okay, now how do I get it there? I can use things like manual therapy is an obvious one. I can use hot packs to then relax that muscle. Again, there's different applications that you can go to target the tissue quality. But if you're trying to achieve tissue quality, then there's different things that are going to work better or worse. So for example, e-stim is great for modulating pain. E-stim does absolutely nothing for tissue quality. If you're doing IFC, assuming. If you're doing NMES or you're doing Russian, obviously that's going to have some different implications, but I would never do IFC, interferential current, with a tissue quality pathology or issue. So again, your intended outcome or your treatment has to make sense, or it has to be aligned with what your intended outcome is. Healing. So this is where it comes into play, the different kind of timelines of the inflammatory or the healing process. And so, for example, if you get somebody one day post ankle sprain and you have a ton of swelling, what is the most effective treatment for it? What are the different modalities we can apply to reduce swelling? If it's a circulation issue and we think that they are either lacking blood flow, or we want to bring more circulation to either promote healing via white blood cell presence, or maybe it's a nutrient and we're trying to lay down like protein, maybe we're trying to create some neogenesis, something along those lines. I think that's when BFR can come into that conversation. Also kind of important to kind of consider the extracellular matrix, like what is the actual development, or the kind of like the way that I learned it was like the pool that's around the cell or around the pathology. If the ECM is full of just like lymphedema, you're not going to have any kind of healing that's taking place because there's no protein, there's no nutrients for the cells to then operate with. Versus if you create good blood flow, you create some movement, now you get a little bit of stimulation to the area, you get some white blood cells that are going to kind of heal the area or keep the area clean. You're getting, what was I going to go with that? You're getting new protein, new fibroblasts, or new collagen formation. Like you're getting all of these tissue healing aspects because you've cleared out some of that swelling or because you've brought new blood flow to the area. Again, here, I think that exercise is an important component. There was an argument, I think it was a Green Bay Packers athletic trainer. I don't remember exactly because this was 15 years ago when I heard it. The argument from the athletic trainer it was NFL for sure, I think it was the Packers, was that you can never speed up healing. You can only slow it down. And so our job as athletic trainers or as PTs is to never get in the body's way of healing itself. All of these different modalities and things like this, his argument was all of these different things are just killing time so that the body can heal itself. Because at the end of the day, the body is healing itself. We're not telling blood to bring macrophages or to bring neutrophils to the area to promote this healing. The body's doing it. We're not telling the body how much protein it needs to bring or how much collagen it needs to bring to this area to stimulate tissue restoration. All of that's happening from the body. So his argument is you can do a lot of different things to slow healing down. You can kind of rip the scab off metaphorically and let it start over. But you can't speed up healing. So depending on your thought process there, a lot of these modalities are ineffective or fall short. Rehab wise, so if your goal is rehabilitation and you're trying to create some kind of restoration of movement, there's a balance component, a proprioception component that we can use modalities to facilitate. There's things like VR goggles I've seen used in concussion or ACL rehabs. You're using these different things to promote the body's awareness in space. I even saw this is probably a bit outdated now, but 2013, 2014, and there was a Nintendo Wii where they had like one of the games was like a balance board or like a skateboard or something, and they were using it to kind of detect asymmetries in either squat or I think they call it quiet stance. And so you're just seeing what the body's eyes closed, how is the body balancing. Muscular re-education, things like Russian stim, and then biofeedback is a growing field that I'm pretty big on, and I think a lot of PTs use, where you're using things like maybe it's NMES and you're hooking it up, but then you're getting there's a few different brands of surface EMG where it's supposed to kind of educate the athlete of contract this and relax this. So usually it's like the agonist you're trying to contract and get a stronger EMG signal, but then you also want a quiet antagonist muscle so that you're not relying on a co-contraction, but you're actually getting true isolation of the individual muscle. So that's something that I've seen. Mobilization, using things like traction or CPM machines to facilitate movement or mobility, and really just trying to create movement, again, leading to the restoration in the rehab process. And then lastly, like I said, psychological, whether that is their perception of this thing really helps me, this thing feels great, this thing makes me feel great, this thing helps me to move, or even if it's just placebo, you tell them this thing does this. And when I beep these fancy lights and they flash and then you make all these noises, this is what it does. And then they're just like, oh yeah, totally makes sense. I felt it. Yeah, that's right. In reality, you were just pressing buttons and you didn't even turn the machine on, but they heard it, they saw it, and they think it works. So placebo is definitely real when it comes to modalities. Any comments, questions there?
Yeah, getting back to biofeedback you had mentioned, I remember during PT school once we used something along those same lines where it was designed for folks with drop foot. So at a certain point during the gait cycle, the the NMES would fire, so it stimulates. I think it was either like the dorsiflexors or the plantar flexors at the appropriate point of the gait cycle, so it
The
facilitated.
dorsiflexors.
Yeah, so it facilitated a smoother gait cycle, which is pretty cool.
Yeah. Yeah. And at that point, because you're using it basically to re educate the muscle is not firing on their own volition. But you can also stimulate the muscle if it is electrically stimulated, the muscle can contract. And so your job is to then repair this kind of neural network so that you get this neuromuscular junction formation and you get this neuromuscular recruitment where you are actively telling your brain is telling the muscle contract now. And you pair, it's just the same as Russian electrical stimulation. You pair the body's contraction with the brain's intent, and so that's how they relearn to contract this muscle, is they get the feeling of the contraction which is being stimulated by the third party, and they pair that feeling with their actual intent, and then that reframes kind of the body's wiring.
Makes a lot of sense. So the NMES or the Russian is really just there to help facilitate that, and then the
Yeah.
brain does the rest of the work. And the hopes is that the more you do that, the more you practice that, eventually you won't need that third party.
Correct. Yep. And you'll see this with a lot of post-op ACLs, where you're doing things like Russian stim. I think it might have kind of gone out of fashion for things that are more comfortable. Russian stim is a very strong contraction, and it is not comfortable. It is definitely painful. But the more modern approach that I've seen is things like the Complex device, which is still NMES, and there's different applications, there's different programs, there's different settings. You can get a painful contraction, but there's different ways. You don't necessarily need to induce a painful contraction to re-educate the muscle. So yes, the electrical component, the kind of, like we were saying, the third party contraction is just there to help the body to relearn it.
Very cool.
Oh, right click instead of left. Moving on to the timeline. So the stages of healing, I think, dictates everything else. Whether they're in the inflammatory phase, or if they're in the proliferation phase, or if they're in the remodeling phase, I'm going to change the modality selection. If they are inflammatory, what is the problem that they're going to face? Well, their body's trying to heal. Okay, don't mess with the healing because they're trying to heal. There's some debate now about the use of cryotherapy for acute injuries. And again, I will rant on this in a couple of weeks, and I will go hard. And I'm actually so I'm writing a narrative review right now, and I am going to submit the abstract for publication, basically saying that I think we're jumping the gun when it comes to cryotherapy, and people think that it's the devil because it reduces inflammation. Well, we need inflammation to promote healing, right? Wrong. Because the specific delay that they saw, so one, these studies haven't been done in humans, it was done in rats. Two, they were done for crush injuries, not for strain injuries, muscle strain injuries, which may be different, maybe not. Ligament injuries, probably different than crush injuries. Regardless, the healing process, what they saw was a delay in inflammation measured by the presence of neutrophils and macrophages. After they saw that delay, what did they witness in terms of tissue healing times? Absolutely nothing. And so there's evidence that even though we delayed inflammation, we didn't delay tissue healing. So how can that be? Maybe our model is wrong. Maybe our understanding of human or tissue healing is wrong. And I bet in 50 years, we will have a much better understanding of the inflammatory process and how we can manipulate it to, again, maybe we don't slow it down. Maybe we don't speed it up, but maybe we don't slow it down. I don't think that ice slows tissue healing. I'm pretty confident that it doesn't. Anyway, rant over. Soapbox is put away. So when I'm in these different stages of healing, okay, if I'm in the proliferation phase, now they're starting to heal. It's probably still not quite safe for them to be doing like full out intensity on their exercise. But in terms of the exercise selection, maybe I can get away from isometrics and the totally safe table-based exercise, and I can start to push them a little bit in the rehab. Or in terms of things like BFR, if it's an acute inflammatory, maybe I'm more cautious with the circulation that's going on, and I don't really want to disrupt the blood flow because the blood flow is so important in the acute inflammatory phase. Maybe I want BFR to be used more in the proliferation phase where I'm starting to remodel this tissue, or in the remodeling phase, and I'm trying to really promote this, what would you call it? Anabolic signal. So think about the stages of healing when you're selecting your different modalities. They should be influenced by the stage of healing that you are in. Treatment time is an obvious one, and I think most of us get this right. If a treatment is going to take an hour to do, you probably shouldn't do it when you only have 30 minutes before practice. Or if it takes an hour of hands-on time and you've got 10 athletes to get to before practice, probably needs to wait until after training. So pre and post definitely have implications there, but most people already consider this. It's just a practical and like common sense issue. Time to take effect. So whether that is something that you do the treatment and then it happens immediately, whether it's acute, so it's something that it's like, okay, well, it takes a little bit of time, but it's gonna happen for a short window. Or if this is something that's more of like an acute accumulation where it's like, okay, laser doesn't work if you do it once. Shockwave therapy doesn't work if you do it once. Whereas some of these other treatments, you do, let's say, joint manipulation. If you do a joint mob and you get some kind of a large movement, and now you get this mobilization, and then now you can start to actually use the joint effectively, it might just be a one treatment thing, and then you never need it again if you get that joint kind of restored. One of the ones that I've seen with this is like ankle. Post ankle sprain, they get locked into dorsiflexion and they'll start to compensate for plantar flexion a lot. If they are stuck in dorsiflexion and they can't get the anterior translation of the talus, then they can't get into plantar flexion. Well, if you can restore the position of the talus, then you can get much more normalized plantar flexion. Once that talus is moving, now they can start to stretch on their own. They can start to activate the muscles much more normally. And you might only need that one joint mob to restore full function in the ankle. And whereas the other, like I said, laser, shockwave therapy, things where we're trying to actually change the tissue itself, those things take time to accumulate, and you have to do those treatments repeatedly for an extended period of time. So if I have a 1 week injury, I'm probably not going to choose a modality that is going to take 2 months to accumulate enough treatments to be effective. I'm going to find something that's much more quickly that can get them back into play, and then maybe consider those other accumulation things once they're playing to kind of supplement. Duration of the effect. So this is one that I think about a lot. Is the effect something that is transient? It's going to happen really quickly. Like in IFC, you get these effects that last maybe 30 to 40 minutes. But in a post-op, like pain management case, like you have to do this thing every hour in order to have true pain management. Versus if they're taking some kind of a medication where the half-life is, let's say, 4 to 6 hours, and then it's like, okay, well, you just need to take new medicine every 4 to 6 hours instead of doing the stim machine for 15 minutes every hour. So thinking about, is this something that goes away relatively quickly, or is this something like medicine where it's got a pretty quick half-life and you're not going to have symptoms resolution for more than, let's say, 6 to 8 hours? Or is this something that's a really long-term effect where it's something like laser where if you get the effect, then theoretically the effects will last for a really long time. And this is where I think rehab comes into play, is that if you can truly restructure tissue and you can strengthen somebody, for example, that is a long-term effect. Strength happens and it takes a few weeks to accumulate, but once you get it, it lasts a really, really long time. Comments, questions about the timelines?
No questions on my end. I like that last part about, strength being the ultimate end goal with any kind of rehabilitation.
If you go back to our presentation on stages of rehab, actually, strength is only like second or third on the end goal. Return to
Right.
play would be the ultimate end goal for athletic trainers.
For so power is going to probably be the last step. But with my population, usually power is not
Yeah.
as important.
Yeah. Anyway, yeah, it's just something that I think of in terms of like, what is the, for example, STEM. I think STEM is great for what it's intended to do, but I hate how it's applied because people will do STEM for weeks and weeks and weeks and weeks for the same like one injury that maybe it's a non-time loss injury, but they've had pain for 3 weeks. Are they doing any rehab to facilitate these longer term changes? And it's what we talked about earlier. Like these modalities should be used to get you through the most important piece, which is the rehab.
Hmm. And maybe in that example, this stem is there to bridge a gap. So you have an acute
Mhm.
injury, use or post-op, use the stem early on when you can't load as much because the tissue is still healing. It's never something you use throughout the entirety of the rehab process. Same thing with BFR. It's there to bridge the gap until we can really load you.
That's the way that I see it. I don't claim to be the world's expert on modalities, but that's the way that I see it. Yes.
I agree.
All right, moving on to the literature review for this week. So there's quite a lot out there on modalities. The Pro Healthcare Products, the Modalities of Sports Therapy, was an article that puts out a pretty general overview of a lot of different modalities, as is the Alton Physical Therapy Sports Rehab for modalities. Both of those articles just give a pretty quick nitty gritty or a pretty quick rundown of the different modalities that are available and used in sports settings. And then the Pullman Regional, there was a kind of slideshow or a PowerPoint presentation that was put together that discussed the common modalities utilized by athletic trainers. So it went through the most common modalities that were used, and then it broke down what it does, what it doesn't do, and then it went through the literature, the evidence to support or deny the effect of these different modalities. So that one's pretty cool and practical for athletic trainers. The media side of things, St. Louis University, I didn't know this series existed, but they have a YouTube channel that is actually pretty good, especially for students, because I think that's what it's intended for, is it's teaching students, but it's also good for athletic trainers to go back and either one, relearn and brush up, or two, learn for the first time, because there's a lot of these things that are kind of implied or get skimmed over, but it's actually good to learn the details or the why behind the reason we do these things. So again, the approach to care for therapeutic modalities is kind of a funny introduction where it's like, okay, wash your hands. You need to check for sensation on both sides, like these things that we always skip over. Uh, but it's good to know that like this is proper practice. And one of the things that they said in there is prep your patient for like psychological effect. And if you can get buy-in, that's half the battle right there. If you can get their mind to think that this treatment is going to help them, it's probably going to help them. They also have a video called Introduction to Therapeutic Modalities. This is much more of a lecture presentation. So this one I think was like 30 minutes, where the first one is like 5 minutes. The 30-minute one goes into the details of these different therapeutic modalities, as well as the theory behind modalities. And so this is what we were talking about earlier with the application, when it has to make sense, your desired outcomes should align, your beliefs and experience should align or overrule I think the order or the hierarchy that they said current best practices and like evidence-based practice is like number one. The number two, I believe, is kind of like a split between patient expectations or patient goals as well as your clinical experience. So those things have to all kind of mesh together to create the best modality application. And then the last one, I've shared this link before, but the sports medicine broadcast at the Memorial Hermann Sports Medicine Update, the speakers or presenters, they go through this podcast interview at the end on the backside, And this one was Kevin Maloney. He's a physical therapist, and he was talking about the different, the rehab toolbox is what he called it. Basically just giving current modalities. I think this was from 2023. And he was just talking about the different modalities that they'll use, when they'll use it, and what they do. So the publication review for this week is a descriptive epidemiology study. And so this paper was basically just looking at what athletic trainers are doing in high schools. So they were looking at the number of visits from different sports. So they broke down across 147 different high schools in 26 different states. And they were comparing with 13 boys sports and 14 girls sports that were reported or documented. So basically they just took their EMR and reviewed all of the different visits as well as services that were provided in those visits. And so they were comparing those for time loss and non-time loss injuries. This was unique in that it was the first one that was reviewing the time loss versus non-time loss, because most studies for epidemiology were injuries that were being reported or documented in these EMRs, but the only ones that were getting reported and documented were the injuries that were losing time. So your ankle sprains, your ACLs, things like that. Whereas some of these kind of bumps and bruises, maybe it's like a thigh contusion and they never lose time, but they're getting treatment for it. So those kind of things were not previously tracked, or they were hard to track, and so they weren't being studied in the research. So this paper is a little bit unique, published in 2015 by the Journal of Athletic Training. What they found, there were a total of, I think this was across 3 years, 210,773 athletic training room visits. That's a large number, but even larger number, 557,381 athletic training services. If you do the math, that is roughly 3 services per visit. And so what you can see is that they're doing not just like one treatment per visit, but they're bringing them in and they're doing a conjunction. So they're doing some kind of exercise was the number one utilized modality. And then number 2 was modalities. Of these visits, 70% of them were for non-time loss injuries. So a lot of these things are just maintenance care for things that are not going to rule somebody out of practice or game. The other thing to consider is that 18.6% of these services were modalities. So again, the majority of these, I think it was like 45% was the highest for exercise prescription, which good for them. Exercise should be in the majority of these cases. But the next largest is these modalities. And of these modalities, they tracked which one were the most frequent. And so in the table, they actually present the data to show which modalities are being used, how often, and what percentage of the modalities these are all accounting for. The most common were hot and cold packs. The second most common were whirlpool treatments, again, hot and cold. So you're getting a lot of thermotherapy and cryotherapy of different forms and fashions, which, again, we're going to talk about in a different week. Followed by e-stim. No surprise there. Everybody loves to manage pain. And then ultrasound. And then from there, it starts to drop off. It was like, I think it was like Normatec was the next one. It was like pneumatic compression. The interesting one for me is that one was following ultrasound. I would have guessed that across high schools, they wouldn't have that treatment available. I would not have thought that, especially in 2015 or 2014, when this data was collected, that the Normatec or other off-brand competitor would have been as present in the high school field, even really I suppose it was probably around collegiate and pro, but to be that present in high school athletic training rooms up there competing with ultrasound, that would have caught me by surprise. I think everybody had a combo unit in the high school setting. Everybody's got stim and ultrasound. Everybody's got some kind of one of those metal tubs that you can fill up with either hot water or cold water, and you can probably use the jets to then create a thermic barrier, or get rid of a thermic barrier rather. And everybody's got hot packs and ice bags, but that one caught me by surprise. So in this paper, again, they have them rank ordered based on the frequency, and you can see which services are being utilized the most. But that was the order of the most common modalities. Any comments, questions before we wrap up?
You had mentioned whirlpool on the previous page. I'm not as familiar with that. Is that just like
Mhm.
the metal tub where you go from warm to cold just to try to get that thermal effect?
Whirlpool is usually describing the movement of water. And so typically, like, let's say you're doing an ice bath.
Mhm.
If you are just sitting in an ice bath, the water that is closest to your skin actually heats up. You create this, it's called a thermic barrier. And so your body creates this kind of coat of water. And so you're touching water that is actually warmer than the ice bath. You are actually not getting as strong of a therapeutic dose because the water heats up around you. If you move the water either by the metal fan or like turbine, so they're actually kicking the water and spinning it. That's the most common. These big loud things, and they go and they kick water around the tub. That is the like most common way that I've seen it. But for a cheaper alternative, all you have to do is every 30 seconds or a minute have somebody take their hand and just stir the water. And if you move the water, it breaks up that thermic barrier. Now you're getting cold water back on the skin. You get a stronger response to the cold water. So that's typically what whirlpool is. It's either a hot bath or a cold bath, and you're using the jets to kind of move that water around.
That makes a lot of sense. So, would you want to do that same thing if you were in warm water as well? Would you like to continue to move it, or it doesn't make a
I
mess?
don't know.
Yeah.
I don't know if there's a reason that you would. I suppose you could probably add some mechanical stimulus. Like if I'm trying to use like thermic before training, you can create a little bit of that gate control, right? Like where you're causing that light touch sensation, and then you're going to modify or manipulate pain based on that. I don't know if there's any evidence to support it, but I suppose it's not really going to hurt anything to have stirring warm water. So if nothing else, maybe it just feels good and you get some kind of a therapeutic effect that way.
Gotcha. Cool. That makes sense.
All right. So to summarize, the way to kind of think, or that the way that I think about modalities is one, which options available are available to me. From those options available, what is my intended outcome and how can I kind of rule things in or rule things out? Is it appropriate to do STIM for a rehab expectation or outcome? Probably not. But what about something like neuromuscular reeducation? Okay, now STIM is probably indicated. um, the other thing to consider is the timelines, the different stages of healing, the pre-practice versus post-practice, the duration of the effect. So I didn't touch on this, but I will now. Stim, probably the effects only last, like I said, 40 minutes. So if you're going to do it after training or after practice, what's the point? You get a 40-minute pain-free window, and then it's pain's back for the rest of the day. Versus the way that I typically apply Stim, before practice, if I can use it, mask some of your pain, get you moving because you have masked your pain, and then now I can get you through the practice. So that's typically the way that I'll apply STIM, is because I know it has a really short-term effect. I will utilize it so that I can get the most out of that effect. Versus if I just have you come in after practice, put some STIM on you, and then it's like, okay, yeah, you feel great, get off the table and go home and sleep. But then as soon as you wake up, your pain's back. So it didn't actually achieve anything. But if I do it before, then I can use it to then produce again exercise, which is more long-term effect. So considering the effect duration is something important. And that should do it for this week. We will get into manual therapy next week, and that'll include things like cupping, different instrument assisted soft tissue mobilization, Theragun or massage gun, pretty much all of those things that are included in the manual therapy discussion.